My name is Rajiv Pruthi, and along with Dr. Chen, I'm currently the co-director for the Special Coag Lab. And first of all, a thank you to the audience, waking up at 7 in the morning to come to this presentation. So thank you very much. So what I'm going to do in the next, before I start, I'd like to know my audience. So by show of hands, how many in the audience are pure clinicians only seeing patients in practice? Okay. And how many are pure laboratorians in the laboratory? Okay, well, good. I used the word laboratorian in Europe recently, and they thought that was a funny word. I'm not sure why, but anyway. So, as Dr. Nichols alluded to the evil anticoagulants that mess up our coag testing in the laboratory, I have some illustrative cases, and I'll be talking about effects. I have no relevant disclosures. And what we'll be talking about is to know the effect of the novel anticoagulants on routine and specialized coagulation assays. I'll touch on certain situations where you might want to perform an assay to measure anticoagulant level and understand the limitations of the currently available assay. So this is a slide from IMS Health that essentially shows the trends in anticoagulant prescriptions. And you can see that warfarin prescription seems to have a trend down, and this trend seems to resemble my 401k retirement plan, whereas the trend for all the direct-acting anticoagulants is on the way up, and that seems to resemble the most recent stock market action. And you can see that there's different anticoagulants, and edoxaban's not on this screen because it was approved later on. However, one of the take-home messages is going to be warfarin's not dead. There are still patients that cannot take the direct-acting anticoagulants, and they will remain on warfarin or be prescribed warfarin going forward. So here's a case history of an 89-year-old gentleman with a new onset of atrial fibrillation, and he recently experienced a thrombotic stroke. He received thrombolytic therapy. That was pretty bold, but he did pretty well. He was having a slow recovery, and he's 89, so he needed at one point a peg tube placed for nutrition replenishment. This is his prothrombin time, and INR is in parentheses, so it was like 16 seconds, 1.6 INR, and this is day 15 post-thrombolytic therapy, so he was getting a little vitamin K deficient, so they gave him some vitamin K. Things improved. And this is a tough situation. Here's a patient with atrial fibrillation and a stroke. It's pretty high risk of having another stroke. So they bit the bullet, and they went ahead and started the apixaban, which is an oral anti-10A inhibitor. And on day 21, I got this panicked phone call saying that they've been replenishing his vitamin K, but his INR is going up again, and they want to know what to do. And as you'll see, it's essentially an effect of the apixaban that's prolonging his prothrombin time here. So we'll touch on effects of the direct-acting anticoagulants on the routine assays and on some specialized assays. So the coagulation cascade that was shown earlier today, very complex. It provides us coagulationists with good job security, and keeps us in business. But really, this is a very simplified version of the cascade that I think is practical and easy to use. You have your extrinsic pathway, and you have factor 7 in it. You have your intrinsic pathway, which converge on a final common pathway. And here's your APTT assay, which assesses your intrinsic and final common pathway. And here's your prothrombin time assay that assesses your extrinsic and final common pathway. Now, shown in circles here are the vitamin K-dependent factors. So warfarin depletes them and prolongs your INR. And here are the direct-acting anticoagulants. So you have the anti-10A agents that are targeting factor 10, and you have the dabigatran that's targeting factor 2. So let's just, so there's also the dilute Russell Viper venom time, which directly activates the final common pathway by activating factor 10. So let's just start by talking about dabigatran. So dabigatran's effect on the prothrombin time. You know, we're actually challenged with the variety of reagents that are available across the world that have different activators, different components, and this chart shows a publication that simply demonstrated the dabigatran's effect on a few different prothrombin time reagents. So you can imagine if a patient comes to an emergency room he's on dabigatran, and he needs some elective surgery, urgent surgery, you do a prothrombin time assay, and you do it to see if there's still any residual dabigatran effect. Well, if the patient goes to an institution that has these reagents, the INR is going to be normal. They'll assume that there's no drug floating around, and they might take him to surgery. Whereas if he goes to this particular hospital, there is prolongation of the INR, and you'll know there is still residual effect, and you might not take him to the operating room. So you can see the point here is there's different effects of dabigatran on different reagents. Why is that? Well, the INR is a calculation that's obtained from the prothrombin time. And prothrombin time, you have a variety of different thromboplastins. Some are recombinant, some are tissue-derived, that activate your extrinsic pathway. And the calculation includes a calculation called a geometric mean, which is a mean prothrombin time of normals, and that can change between reagents and between lots. And then the ISI varies with the reagent instrument combination. So you can see all these variables that affect the INR. And please note, the INR really was meant for patients on warfarin, not on direct thrombin inhibitors. So I do have a bit of a challenge trying to understand when they present data like this, rather than showing the prothrombin time, they're showing the INR, which is really not a very good way to do it. So the previous slide I showed you was prothrombin time. I'm going to show you the APTT on this slide, and it essentially has the same effect. Now, in this case, the APTT is actually a little more sensitive, probably a lot more sensitive to dabigatran than the prothrombin time is. And you can see, however, there's still variation depending on the APTT reagent, which are listed right here. So again, the potential reasons for discrepancy depends on the sensitivity of the APTT reagent. It depends on why you're implementing a reagent in your lab, whether it's for heparin sensitivity, whether it's for lupus anticoagulant sensitivity, or coagulation factor deficiency sensitivity. So each has a different purpose. And then, of course, it depends on what instruments you have, whether you have mechanical endpoint or optical endpoint instrumentation. So what does this actually mean for you as practitioners and for the patient that comes to your office or to the emergency room? In one study, where they looked at PT and APTT assays in patients on therapeutic dabigatran dosing, 30% of the prothrombin time results were normal, and 18% of APTT results were normal. So the take-home message here is you can't really rely on these assays to exclude residual drug effect. Let's look at the thrombin time. It's another very sensitive assay that is very sensitive to heparin and also to dabigatran. And you can see that this seems to be an almost linear relationship. In the lab medicine world, there's this R-squared value that we'd like to be close to 1, so that demonstrates that this assay perfectly correlates with the drug concentration. However, this is the ideal, well, this is near optimal, but when you actually do it, this is an experiment we did in-house, looking at our thrombin time reagent, and we got a curvilinear relationship. So there's a steep increase in the thrombin time with low concentrations of dabigatran, but then it just flattens out. So again, if you have a thrombin time assay in your hospital or laboratory, I think the only information you get out of that is yes versus no. There is drug or there is not drug. However, there are a variety of things that cause the thrombin time to be abnormal. If there's residual heparin in the specimen, it'll prolong the thrombin time. For instance, the sample may be collected from a central catheter. Monoclonal proteins can prolong the thrombin time. So there's a variety of things you need to keep in mind. However, this is the relationship in our laboratory, in our hospital, with dabigatran. So the bottom line with dabigatran is it prolongs the clotting times. The degree of prolongation will vary with the reagent and instrument combination. They're not accurately reflective of drug levels. Although it's theoretically possible for each lab to calibrate their prothrombin time to drug levels, it's not really advisable, and you'd have to really recalibrate each time you change your prothrombin time lot. And if you get a prolonged prothrombin time or APTT, at this present time, we're not sure is there a safe level at which you can actually take a patient to surgery. And then the downside is if you're doing a mixing study on somebody with your APTT on somebody on dabigatran, it's going to be inhibited. And as Dr. Nichols showed, you can mistake that for either a lupus anticoagulant or sometimes a factor VIII inhibitor. So moving on to the anti-10A agents, I'm just going to show you the rivaroxaban. All these graphs look the same for all the other the drugs. So in order to avoid overwhelming data, I'm just going to show you a couple of representative graphs. So again, a variety of prothrombin time reagents, and you can see the different effects with rivaroxaban, similar relationship. And again, with the APTT, it's a similar relationship. With progressively increasing concentrations, the clotting time goes up, but it varies with reagent. The degree of prolongation will vary. So again, coming back to what does this practically mean if somebody's on rivaroxaban, they're in the emergency room. Now, note the anti-10 agents do not affect the thrombin time, so that's not it's not useful at all to detect these drugs. Now, in one study, 32% of patients on therapeutic rivaroxaban doses, the prothrombin time was normal. So if you want to exclude drug effect, prothrombin time 32% of the time, they were normal. And APTT is less sensitive to anti-10A, direct-acting oral anti-10A agents, because in this study, 80% were normal at trough levels, and 13% were normal at peak levels. So you can see there's that variation you need to keep in mind. So the bottom line here is there's a variable prolongation, just as with dabigatran, and one cannot establish a cutoff to exclude or detect presence of drug. And at that, again, there's no known safe level for PT or APTT at which you can actually tell a surgeon, go ahead and do your surgery. This table summarizes what I've just talked about, effect on the prothrombin time, effect on the APTT, and then fibrinogen class is probably a very commonly ordered assay or available assay in most laboratories. And the anti-10A agents actually do not affect the class fibrinogen, and dabigatran also doesn't at low concentrations, but at high concentrations it artifactually lowers the fibrinogen level. So you might mistake that patient as being in DIC or having hypofibrinogenemia. And again, the dabigatran prolongs the thrombin time, but the anti-10A agents have no effect on the thrombin time. Now, this effect is important because if we've on occasion receive, in our special coag lab, we receive requests to do inhibitors tests on all the APTT factors, the 8, the 9, the 11, and 12. And so our lab personnel bring that request to us, and we call the clinician and we say, you know, it's very unusual to have inhibitors against every factor. Can you tell us a little bit what you're looking at? And the story usually ends up being that this patient had a prolonged APTT in our hospital. We did a mixing study, and it was inhibited, so we're looking for an inhibitor. And then invariably, when you dig further, the patient is either on dabigatran or gatroban, and we end up doing what we call a prolonged PT-APTT profile, but only once the patient is off the anticoagulants. So we talked about the effect on routine assays. Let's talk a little bit about the effect on specialized assays. So here's another case history of a patient who's 60 years old who presented with a deep vein thrombosis. He was placed on dabigatran for treatment, and special coag tests were performed. And you can see his APTT here is prolonged. And when you do a mixing study, that's prolonged for our laboratory. I don't show the reference ranges. And here's the results of the dilute Russell Viper venom time. And you can see that this is the screen is prolonged. You do a mix, it's inhibited. And when you put in a phospholipid step, the confirm shortens compared to the screen. And so that's diagnostic of a lupus anticoagulant. And the stake lot APTT is somewhat positive, maybe equivocal. So at this stage, by show of hands, let's see. How long would you continue anticoagulation? This is lupus anticoagulant. Would you continue long-term? Anyone want to do long-term? Okay. How about only 3 months? How about 6 months? How about 1 year? I should have put another option here. How about we repeat the testing? Okay. All right. Because right here you see this thrombin time. I didn't mention it, but it's there. It's prolonged. So there's this patient's either on heparin or most likely, as I mentioned, he's on dabigatran, which can result in a false positive lupus anticoagulant. And so we took the patient off dabigatran and repeated his assays, and you can see the DRVVT, lo and behold, it corrected. I mean, there was some prolongation, but it corrected on mixing study, and the stake lot became completely negative. Now, the thrombin time was still a little prolonged. This gentleman actually had a monoclonal protein as well, and that sort of inhibited his thrombin time. So dabigatran, what it does is it can prolong and inhibit your screening assays. And that can give a false impression of either a lupus anticoagulant, and that puts the patient at risk for thrombosis, or a specific factor inhibitor, which is a bleeding disorder. And in the laboratory, we don't always get that clinical information, so we're always reaching out to our clients to, see if we can get that information. And however, I think if you order these tests, if you need them, off anticoagulants, that's probably the biggest bang for your buck. If we end up in the lab pursuing factor 8 inhibitor testing, we'll get a false positive Bethesda as well. And then, as I mentioned, it has either no effect, or at high concentrations, it may lower the fibrinogen level. But this is the biggest impact on patients. If you do this testing, if the patient's on an oral direct 10A inhibitor or dabigatran, you'll get a false positive lupus anticoagulant, and you might end up treating that patient longer than they really need to be with anticoagulants. So it's important to be cognizant of these effects. Now, in your conference app, you will have the slide and you'll have the reference. And if you want to pick one paper to read, this was a very well-written paper by Dr. Adcock and Bob Goslin, and they provided a very nice overview of the effect of these direct-acting anticoagulants on coagulation assays. And I will just summarize and walk through these very briefly. What about their effect on the antithrombin assays? There are two types of antithrombin assays. There's a 10A-based and a 2A-based. And so for the 10A-based assay, dabigatran has no effect. But on the anti-10A, with the direct-acting anti-10A agents, you can actually overestimate antithrombin and potentially miss congenital antithrombin deficiency. Now, for the 2A-based assays, it's the opposite effect. Now, protein C activity, there's a clot-based and a chromogenic assay. So the clot-based assays, both the drugs classes will overestimate protein C, and you may potentially miss a diagnosis of hereditary protein C deficiency. But these drugs don't have any effect on the chromogenic assay. Protein S activity is a clot-based assay. Again, you can overestimate. The antigen, however, neither of these drugs will affect the antigen. Now, this is important. Dr. Haidt very nicely, eloquently mentioned that it's really the APC resistance assay that provides you with the most value. But if you perform this test on a patient on one of these drugs, you can actually get a falsely normal result. So you need to be cognizant of this effect. And I've already mentioned the false positive effect of lupus anticoagulant. So in conclusion, the effect of direct-acting anticoagulants on lab assays, they have variable effects on routine and specialty coagulation assays. It's really hard to remember all of this if you don't do it every day. So getting that one article actually it'll be very useful, and I think we all have our peripheral brains on our smartphones, so you can store that somewhere. Measurement or presence or absence of this drug may be useful in certain circumstances. So the FDA has approved these drugs for clinical use, and they essentially say you don't need to monitor them, and that is still true. But there are some circumstances you might need to measure a level to assess compliance. If a patient presents with either bleeding or thrombosis, you might want to know what the drug level is. If it's a pre-op patient who needs urgent or emergent surgery, you might want to know what the drug level is. And in cases of overdosing. Now, I've talked about the effect with these routine assays, but at the present time, there are no FDA-approved kits and calibrators that are combined to be able to give, for a lab to be able to implement these as an FDA-approved kit. There are a lot of regulations that are coming down to labs, really restricts us, but right now, labs are having to develop these assays or validate these assays and offer it as a lab-developed test, which is a much higher level of effort to have them available. However, there are some labs that actually offer these assays by mass spectrometry or by the current anti-10A kits, but using the appropriate calibrator. So there are current anti-10A kits, and I know some hospitals are monitoring unfractionated heparin with anti-10A assays, but the calibrator we use there is unfractionated heparin. So if you substitute that with one of the oral direct anti-10A agents, those actually are fairly accurate in measuring these levels. And there's, I forgot to put in here, but there's an assay for dabigatran as well. It's the dilute thrombin time that's available. So I thank you for your attention. I think we have about 5 minutes for questions. And I'll be available after the session as well if there are any questions. I don't see any hands going up. No. Okay, no problem. We'll go ahead with the next speaker. Okay.
Hi, morning. I'm Fernanda from Brazil. I would like to know what's the time when you stop the dabigatran or rivaroxaban, what's the necessary time to perform a lupus anticoagulant test with safety, like 3 days, 4 days? How long do you think?
Yeah, so the question was, what's the time interval between stopping one of the direct-acting anticoagulants and performing the testing if you need to? Generally, if your renal function is normal, 2 to 3 days is adequate. Yeah.
Maybe it's a question about a further slide. Speaker, what's the PNP-PTT measure?
So the APTT is your standard APTT assay, and to test for lupus anticoagulant, the next step is to do a mixing study with normal plasma, and it should be inhibited. But then we need to demonstrate that inhibition is phospholipid dependent. So that's where the PNP, which is the platelet neutralization procedure, comes in. That's the source of phospholipid.
Can you measure the lupus anticoagulant when people are on warfarin? Say if they're on one of these direct thrombin inhibitors and you want to, you feel the need to keep them on anticoagulation, you're afraid to stop, but you want to see if they have the lupus anticoagulant. I've heard yes and no. What do you feel about that?
So the question is, do you feel it's safe to interrupt anticoagulants to do this testing? Is that what you want to do? You do it on warfarin. On warfarin? You can, but we've observed that we're getting false positive lupus anticoagulants even on warfarin. Something changed with the reagent. One way around that is if you switch them over to low molecular weight heparin, if you can, and then you just have to, basically 24 hours after the last dose of low molecular weight heparin, get the blood sample, get them right back on the low molecular weight heparin. That probably gives you the shortest time interval of anticoagulation free. Yeah.
You showed that there's really no safe PT or PTT if somebody is on a direct inhibitor for surgery or emergent procedures. If your hospital measures heparin in the anti-10A assay, but does not offer measuring apixaban, could you use that instead?
I've done that against my better judgment, but I've done that, absolutely. It gives you an idea there's something there. It won't be very accurate. And there are some other labs that say that it over-measures. The current anti-10A assay just overestimate what's actually in the patient. There's no good studies that I can point you to, but yes, I've done that too. Yeah.
Are the direct oral anticoagulants approved in treating lupus anticoagulant?
The question was, can you use the oral direct anticoagulants for patients who have lupus anticoagulant? They're not specifically approved for that indication, and there are anecdotes and there are case reports and case series that suggest that patients with venous thrombosis and antiphospholipid syndromes, they actually don't, the direct-acting anticoagulants don't work as well as warfarin does. Yeah. There's some in vitro data that just came out from McMaster that suggests they have a higher level of thrombin generation as well. But they were clinically, this was a randomized study, but there were no difference in clinical endpoints.